off here talking about, I always like to say oogenesis, but oogenesis in the ovarian cycle. Now, really, please do me a favor, pay super close attention. All right, when we're talking about the ovarian cycle, okay, we're going to be talking about what's going on in the ovaries, but the other structures that are going to impact what is happening in the ovaries. All right, the ovaries are the primary reproductive organ of the female reproductive tract. That's where the oocytes are. That's where the eggs are, okay? So we're going to discuss all the stories here of what's going to occur with the ovaries. So that means we're going to be dealing with follicles and the oocytes, okay? So this is going to occur around age 11 to 12, all right, depending on when the female enters into puberty, all the way to menopause, which is anywhere between 45 to 55 with natural onset of menopause, okay? Other conditions can bring early onset menopause, and of course you can always have women that enter menopause later in life, okay? So of course we're always going to start with this guy right here, our friendly hypothalamus gland. That's the master gland, okay? And so it's going to release the gonadotropin releasing hormone, of course, remember, the hypothalamus releases two types of hormones, all right? I shouldn't say two types. The type of hormone that the hypothalamus releases are what we call regulating hormones, all right? They're either going to stimulate or they're going to inhibit, okay? So the gonadotropin releasing hormone is going to stimulate the anterior pituitary, keep in mind, anterior pituitary, to release, all right, the luteinizing hormone, LH, and FSH, the follicle stimulating hormone, right? It's follicle, all right? So that means we're going to be dealing with ovaries here, okay? So when we talk about the ovarian cycle, there's 3 phases to it, all right? And so therefore, if it's a cycle, it's going to have a cyclical nature to it, a beginning and an end. We'll have a middle even, okay? So we're going to talk about all of these events for a 28-day cycle, okay? That's what we consider to be, and I hate to throw the term out there, normal, but that's the usual length of time, 28 days, okay? And obviously, I know some folks, I had a patient that had their ovarian cycle, or not their ovarian cycle, but they menstruated once every 3 months for whatever reason. Doctors couldn't figure it out, okay? But this is for the 28-day cycle. So there's 3 phases, all right? The follicular phase, ovulation, all right, and the luteal phase, okay? So the follicular phase basically is the first half, all right? The luteal phase is the second half, and then the ovulation is only 1 day. It's midway through the cycle, okay? Usually day 14, okay? All right, so when we talk about the follicular phase here, all right, I've mentioned this before, all right? This is where we're going to start to ready some of our follicles. We're going to start with the primordial follicles, and roughly about 20 of them are going to start to undergo maturation. So they'll go primary, all right, and not all of them, all right. In fact, usually only one will make it to a mature follicle, all right. We don't know why. We don't know why, but we do know, all right, that LH and FSH are going to stimulate that maturation process, okay? Now, whereas at the same time, you remember the granulosa cells, those are the cells that are on the outside of the zona pellucida and deep to the fecal cells, all right? They're going to release inhibin. And I don't know if you remember, we saw inhibin when we were talking about spermatogenesis. And inhibin helps to decrease the number of reproducing sperm. So similar here, all right, inhibin is going to stop or halt the production of follicle-stimulating hormone, all right? And that is then going to decrease, all right, the likelihood of excessive follicular development. So we're not having like 50 follicles, all right, matured, all right? We only need 1, okay? That's all we need, all right? So that's based on a negative feedback system, okay? So we'll get into that in a second, but I just want you to know the players that are involved. The follicular cells are going to release inhibin, all right, and that's going to prevent, all right, FSH from stimulating more primordial follicles into going into that maturation phase. All right, now you have a lot, you got 400,000 of them, all all right? But again, we're only going to have, all right, by the time ovulation occurs, one mature follicle. All right, so we'll see, all right, through that maturation process, we're going to wind up with a secondary follicle here. All right, vesicular follicle means a mature follicle, by the way. All right, so this is where we start to see that antral follicles start to occur. We start to get that cavity, all right, that space inside the follicle starts to fill up with fluid. Then we'll start to see the oocytes start to migrate. I shouldn't say migrate. It gets more forced to the periphery. It gets pushed against the side there. All right, and then it's getting pushed to the side for that period during ovulation. So for that release there. Okay. So we start to see the oocyte get pushed to one side. And at that point, once it's there at the periphery, okay, we then consider that follicle a mature follicle, all right, and that the oocyte is going to then eventually become a secondary oocyte, okay? So here, when we have that antral follicle, that's that space inside there, all right, the oocyte has now completed meiosis 1. All right, I'm going to come right back to this. That's on this. Where are you? Come on, buddy. All right, this is that picture I was telling you about. All right, it's great. I'm not going to go through this, but it's in your book. All right, 28.6. All right, where for oogenesis here, it has, all right, the follicular development coinciding with the oocyte development. So you can see, all right, what is going on. And if you really are interested in this, you can actually see the histological slides and see what that presentation looks like. All right, but this will tell you what's going on with the oocyte and what's going on with the follicle at certain stages of maturation or development here. Okay, so at the end of meiosis 1, remember, we're going to wind up with 2, all right, haploid cells. In the oocytes, we actually have the secondary oocyte, all right, that's the actual functional cell, and then we got this thing, all right, and that's called the polar body, okay, and that thing is non-functional, all right, but it's also haploid, okay. All right, let me come back here. Did I skip? No, right here. Sorry, too far. Okay, so this is what we're going to see, all right, in the latter part of the follicular phase, all right? The oocyte's going to complete meiosis 1, all right? And we're going to then, all right, see that as a result of that, we have 2 cells, okay? We are going to have our polar body here, all right? And then we're going to have our secondary oocyte, all right? So here we'll start to see meiosis 2 beginning, all right? And that secondary oocyte is going to progress, all right, all the way up to metaphase 2. And then it stops there until it's fertilized. If it's not fertilized, that's it. It degrades and it goes away, all right? But in order to finish meiosis 2, it needs sperm, and it's 23 chromosomes, okay? So keep that in mind. So all this will happen, all right, if this oocyte, after it completes, all right, meiosis meiosis 1 and then progresses to metaphase 2, all right, if it's not fertilized within that 24-hour period of it completing, all right, the metaphase 2, it needs to be fertilized or it degrades and it goes away. Okay? All right, ovulation, 1-day period, okay? Usually middle of the cycle, 14-day. All right, here is where we're going to see, all right, if we're checking your hormone levels, we're going to see a huge spike in the luteinizing hormone secretion. They call it the LH surge. All right, so you'll see an increase in estrogen leading up to that. And I'm going to show you some pictures and some graphs here in a moment to kind of explain that to you. All right, so that LH surge will, that increase in estrogen, the high level secretion of estrogen, will eventually trigger, all right, what we call the LH surge, which is a massive amount of LH being released from the pituitary, all right? That phenomenon causes, all right, the antrum, our mature follicle, to swell up and burst, all right? And as that does that, all right, it releases the secondary oocyte, okay? And ovulation is 1 day period of time. So if you're tracking it and you're looking at the hormone levels, you'll start to see, all right, you'll see a steady increase in estrogen, but then it takes off at a certain point. Usually near the latter portion of the follicular phase, it really starts to go up. All right, so you know, all right, once it gets up close to the peak for the estrogen release, we're getting close to ovulation, that LH surge, and that's what folks will do to monitor if they're trying to have a baby. All right, they'll monitor estrogen levels, and when they see it starts to take off, then they know they're close, all right, to that LH surge there. Okay, so then the oocyte gets released, all right, and we enter into the luteal phase. Now this is all having to do with the ovaries here. Okay, so now, all right, we've expelled our secondary oocyte, all right, into the fallopian tube, hopefully, all right, and it's going to make its journey towards the uterus. Hopefully on its way, early on, it'll get fertilized by some sperm, all right? So here now, our mature follicle starts to convert into our corpus luteum. And I said this on Monday, all right, that I want you to think of the corpus luteum as a small little endocrine gland, okay? It's going to release estrogen and progesterone. All right, and both of those hormones are going to help to prepare the uterus. We've already started to prepare the uterine lining, the functional layer of the endometrium. All right, it's starting to increase in its vascularity. It's starting to get a little bit thicker, getting ready for implantation of the preembryo. All right, in the event of fertilization. Okay, so what we're seeing here, all right, we're going to continue that. We're going to secrete our progesterone and our estrogen because it's huge to prepare that uterine lining here, all right, for implantation. Okay, and I'll show you a little cool picture here. So this will last for about 10 to 13 days. So that's how long that corpus luteum is going to be producing those hormones. Now, if there's no fertilization, all right, then that corpus luteum then degrades, breaks down, and turns into a corpus albicans, scar tissue, and then it goes away. And then we start the cycle over again, all right? So if it does, though, here's the cool part. If fertilization does occur, all right, and HCG is produced, the human choricotropic, oh, geez, give me a second. All right, HCG, all right, when that hormone is produced, it then keeps the corpus luteum alive or sustainable for about 3 months. So this ruptured follicle is going to be acting as an endocrine gland for up to 3 months. After 3 months, then the placenta takes over, and we don't need the corpus luteum. Then it degrades away. All right, I'll talk about that in a second. Okay? So if there's no fertilization, we see the corpus luteum, all right, regress. We stop secreting progesterone and estrogen. What happens to the endometrium? It sloughs off the uterine lining there. That term is what we refer to as menstruation, all right, as it's shedding it, all right, and I keep wanting to say patient, and the mother, well, the woman, all right, is when she gets rid of the lining, we call that menses, all right. When that occurs, we're at the end, all right, of the luteal phase, all right. This whole thing will start, all right, in puberty, usually around age 11 and 12. And when we have our first menstrual cycle, we call it menarche. No, I'm just kidding. Menarche. Malarkey. Has anyone ever heard that term, malarkey? All right. Anyways, all right, we start to see the onset, all right, usually at that age, all right, between 11 and 12. All right, I've already shown you this 100 times. Seriously, though, I know this stuff can be somewhat tough, especially when we're talking about oogenesis, but just glance over this. It really helps to see what the stages are for follicular and for oocyte development and where we are in the meiotic cycle 2. All right, if you're in meiosis 1, meiosis 2, if you're arrested in prophase 1 or arrested in prophase 2. All right, so this picture here is showing us, okay, when we're talking about all the different hormone changes, and I'm going to do my best to try to point this out. And I was told that when I zoom in on this, if you're watching at home, it looks blurry. That's true then, yes? Oh, all right. Someone told me all right. Someone said when I zoom in on this, it becomes blurry. All right. So what we're seeing here, all right, is a couple different areas of what's occurring. All right. The top one here is showing us, all right, FSH and LH levels on a 28-day cycle. All right. Also showing us the development of the follicle. All right. We can see here. Oh, no, wait. That's the that's the follicle, and then what's happening here during the ovarian cycle. This one down here shows us what's going on with estrogen and progesterone, and then this guy down here shows you what's happening with the functional layer, all right, of the endometrium. Okay, I'm going to be referring back and forth to this, okay, because I could spend the rest of the time in class today just trying to explain this whole page to you, but I will as we go through the class. But what I want you to understand is, all right, you can see here. All right, when we're dealing with estrogen and progesterone, okay, we talked about when the primary follicle is releasing estrogen. It's in low levels. So as we're starting to release low levels of estrogen during follicular development, you can see we're starting to increase the uterine lining, okay? So how we mark the onset of the ovarian cycle is the first day of menses. Okay, when the bleeding and we start to shed and break down that functional layer, the first day of menses, all right, is what we consider the beginning of the ovarian cycle. That usually lasts for 5 days. Okay, and so after that, all right, we start to see this steady incline of estrogen. All right, and that's of course coming from the primary follicle. Then we'll start to see this is that estrogen increase that I was describing to you folks. All right. So as we're getting close to ovulation, we're going to see a sharp increase in estrogen. And just as it starts to drop off, that's when we get the LH surge. When we get the LH surge, then we get the oocyte being expelled from the follicle here. Okay. So as I go through this, I'll kind of draw some of this stuff together. Okay. So, menopause. With every beginning, there is an end. And menopause is the end, all right, to the menstrual cycle, all right? Usually occurs between the ages of 45 and 55, all right? This is in normal folks, but you can also have some sort of pathology or medical condition, all right, that can cause the onset of menopause too, prematurely. All right, but usually if a woman is not having a cycle for the period of 1 year, all right, then they're considered to be in menopause. All right, so no more ovarian follicles, all right, will be released, will be maturing, all right, when this person is in menopause. Okay, so we'll see a significant decrease in progesterone and estrogen. All right, and this is when you hear folks going on hormone replacement therapy, okay? Because don't forget, your adrenal glands do produce a small amount, all right? But the primary organ is going to be the ovaries for the production of progesterone and estrogen, all right? The good thing is, even though you're not producing these hormones and your hormone levels drop and you have some issues because of that, the one good thing is you're no longer having menstrual periods. You don't have to worry about that, but you do have to worry about hot flashes, all right? And some of the symptoms have been described as mood swings, all right? But the one that I hear the most from patients is the hot flashes, especially down here in South Carolina. It can be quite warm. All right, let's talk about the ovarian cycle, oogenesis, in detail now with the story from the beginning to the very end and all the players that are involved. So that means we're going to talk about what happens to the hypothalamus, what happens to the anterior pituitary, and then what's going on, all right, with the follicles here, okay, in the ovaries. All right, so let's start off here. Gonadotropin, releasing hormone, gets released by the hypothalamus. We learned this, chapter 17. We knew this. It's going to stimulate the anterior pituitary now to release, all right, follicle-stimulating hormone and luteinizing hormone, okay? So both of those are going to target the ovarian organs there, okay? And they're going to stimulate follicular maturation and development, all right? So this is going to help cause those follicles to mature, and as such, if you recall, as these follicles are maturing from primordial to primary to secondary, all right, our granulosa cells are going to be releasing, all right, our estrogen, okay? So that's what we're talking about, secretion of other hormones, and we'll talk about this. So as this starts to go on, all right, we're going to be dealing with some positive feedback mechanisms here and some negative feedback mechanisms here. All right, we're going to talk about our first negative feedback mechanism right now, okay? So as our ovarian follicles continue to mature, they're going to start to release inhibin and low levels, all right, of estrogen, low levels. And as a result of that, all right, those low levels of estrogen and the inhibin, they're going to cause a negative feedback on the hypothalamus and the anterior pituitary, all right, to slow down, all right, decrease the release of luteinizing hormone and follicle stimulating hormone, okay? So there's two things I can show you on here. Let me just come back to this one right here. All right, so you can see how we have a little bit of a drop off here, okay? We're going to start with that negative feedback to slow down and decrease the release of those two hormones, all right? Let me show you on a different diagram. I'm going to come right back to this. This one here. Whoops, God. Come on. All right. So here we can see, all right, hypothalamus stimulates the anterior pituitary to release follicle-stimulating hormone and luteinizing hormone, which will help with the maturation of these ovarian follicles, okay? So as they are starting to mature, they'll start to release low levels of estrogen, all right? So as such, the inhibin then and the low levels of estrogen will go back and cause inhibition of the hypothalamus and the anterior pituitary, so we're not producing any more of the follicle stimulating and luteinizing hormone. The reason why is we don't want to have 1,000 primordial follicles transitioning and maturing into primary oocytes and secondary oocytes. It helps to, because once we get our first blast out there, only a couple of them are going to respond, about 20 or so, like I said before. We don't want hundreds in the ovary and the other ovary to start causing maturation. So that's why we're going to inhibit this. We've got our follicles, because once we start to release the low levels of estrogen, then we know what we did is working, all right? The anterior pituitary knows, okay, I'm starting to get some estrogen feedback. That means my primordial follicles have matured into primary oocytes, or excuse me, into primary follicles and secondary follicles. It's starting to release that estrogen, all right? So once that estrogen hits those tissues there, all right, those endocrine glands, we're done. We can shut that down. That machinery does not need to be reactivated right now. So that's what happens, all right? So now those low levels of estrogen are going to help continue with the maturation here of our follicles here, of our ovarian follicles. Do y'all seeing that right now? That's the primary, excuse me, that's a negative feedback loop, okay? Negative feedback. You learned that back in chapter 1. Woo-hoo. All right, where was I? Okay, so now those oocytes are making their own estrogen, which will help with the continued maturation of the ovarian follicle. So in this situation now we're going to see as that follicle now has reached that mature follicle stage, now it's going to start pushing out large amounts of estrogen, going back to, I know I'm flipping back and forth a lot. Now you can see, here's the low levels of estrogen production. When we see it spike here and jump up, now we know we have a mature follicle and we're close to ovulation. So if we're trying to track a good time to get pregnant, this is a good time to get pregnant or get ready to start. okay? We see an increase in the estrogen levels. That's because we have a mature follicle that's really pumping out some high levels of estrogen. Good, because we're getting close. We know, all right, this as the estrogen levels start to increase, we're getting close to this, our LH surge, all right? And when that happens, that means, all right, the mature follicle has released our secondary oocyte. Where am I going? Here. All right. So because now, all right, you know what a positive feedback is, all right? The resulting action is always in the direction to further the stimulus, whatever that is, all right? We saw that with nursing, breastfeeding, okay? Blood clotting, same thing, all right? So that mature follicle is now going to produce even more estrogen. So that's positive feedback, okay? So let me see, make sure I got all that in my picture here. All right, that's where we're at now. Here we go. Okay, we're at our mature follicle. We're starting to release higher levels of estrogen. All right, so we're going to talk about the second half here. Okay, so with our feedback loop continuing with that increased estrogen, bang, now we hit the LH surge. All right, and the anterior pituitary, all right, is going to release, all right, a massive amount, all right, of that luteinizing hormone, and because of that, it will trigger ovulation. No surge, no ovulation. All right, you need that surge to occur. Okay, so now that mature follicle has expelled the oocyte, okay, and it now regresses into the corpus luteum. Well, we already know what happens with that, all right? The corpus luteum now is going to secrete large amounts of progesterone and estrogen to help with preparing the uterine lining, the functional layer there of the uterus, for implantation. Cool. At the same time, though, guess what? It's going to release inhibin. All right? So we know what inhibin does. It's going to inhibit, all right, the hypothalamus and the anterior pituitary from releasing any more FSH or LH. We don't need that anymore. We've done it. We have gotten the mature follicle to expel the oocytes into the fallopian tube. Now we're just hoping and praying that we'll have some fertilization going on. Okay? If that does not happen, you can say goodbye to the corpus luteum within 10 to 13 days. Okay? 10 to 13 days, that goes away. And if there isn't any fertilization, then we repeat the cycle. Okay? We're going to repeat the cycle. But at the end of, all right, the 10 to 13 days, then we're going to break down the functional layer. And then that's when we'll have menstruation for 1 to 5 days. That's the beginning of the next cycle. Okay? So we'll see this. Let me show you a picture. I love these pictures. You know this. All right? Let's bring it over here. Okay. So here we see our mature follicle. Okay? And it's pumping out massive amounts of estrogen here. And that massive amounts of estrogen is going to stimulate the hypothalamus and the anterior pituitary, all right, to give us that LH surge. Once that LH surge occurs, then our oocyte is expelled here, all right, from the primary follicle into the fallopian tube. Okay? And the oocyte enters into the fallopian tube, hopefully to get fertilized. All right? Then our ruptured follicle is going to regress here into the corpus luteum. The corpus luteum is going to continue on to produce that progesterone and estrogen, getting the uterine lining ready. All right? In addition to producing those two hormones, it's going to produce inhibin, which is all going to negatively inhibit, all right, the hypothalamus and the anterior pituitary from releasing any more hormones. Okay? Not every single hormone, but I should say it'll inhibit it from releasing FSH and LH. Okay? So I'm done. It's going to keep it in check for 10 to 13 days. Okay? Again, great figure here. If you're not quite clear on the whole process, look through it. Okay? Okay. So now, all right, we've actually released the oocyte. Let's say it gets fertilized, all right? At that point then, we call that structure a pre-embryo, all right? And what will happen is that pre-embryo will travel the remaining distance of the uterine tube, or excuse me, the fallopian tube, enter into the uterus and implant onto the endometrium somewhere. Once that occurs, I mean, right away, when that occurs, it releases human chorionic gonadotropin. Couldn't say it earlier, now I can. All right, HCG. That's the hormone that when you take a pregnancy test, that's what's detected in your urine. That's what we use to find out if you're pregnant. Okay? So this hormone here, all right, is going to sustain, all right, our corpus luteum. All right, for 3 months. It's going to do this. This hormone here, well, eventually its amounts will decrease. All right? But for 3 months, the corpus luteum is going to produce estrogen and progesterone. Okay, like I said, it's a temporary endocrine gland. Okay, but it's the human chorionic gonadotropin, all right, that is going to help stimulate the corpus luteum here. Okay, after 3 months, placenta takes over, the corpus luteum degenerates into a corpus albicans, and it's gone. Any questions about that? It's confusing when you're trying to keep track of what's the oocyte doing, what's the follicle doing, what is the what hormones are being produced by what. All right, it's a lot to kind of take in. So I'm trying to keep it as streamlined as possible here. Okay, we're done with the ovaries. Woo! Not bad, not bad. All right, let's talk about the fallopian tubes. Now listen, the next several slides are going to be review because you've seen a lot of these slides already in lab. Okay, so if it seems like I'm going through them somewhat fast, it's because I am. All right, because we've seen these already. All right, so the fallopian tubes are going to be the structures that are going to come off the uterus laterally on both sides there. Okay, and it's going to be the structure that is going to transport the oocytes or the pre-embryo, if it's fertilized, all right, into the uterus. Okay, so remember what I was saying. You have the uterus, and then you've got the ovaries on either side, all right, with the fallopian tubes going out towards the ovaries. And it's like someone just took a bed sheet, like they would hang it over a clothesline, right? You have the broad ligament, all right, that hangs over the uterus, the fallopian tubes, and the ovaries, like a bed sheet over a clothesline here, all right? Well, that forms this structure here called the mesosalpinx. And that's going to be that top portion of the superior portion of the broad ligament as it's covering over the fallopian tubes and the ovarian ligament there, all right? That space between, and I would try to show you a picture because hold on. I'll come right back. I thought I had a picture on here. There it is, all right? Here's the mesosalpinx right up here, okay? So here's your fallopian tube, here's the ovarian ligament, and in between, there's the mesosalpinx. But this whole thing is the broad ligament. Here, let's do this. That's faster if I do it this way. Nope, I can go far back enough. Okay. So the first part of our fallopian tubes is the infundibulum. And I don't know about you, but I always think of it, yes, it's a funnel shaped, all right, but just the spelling of it, all right, makes me think of funnel shape because you have F-U-N and funnel, F-U-N and infundibulum. Okay, so this is the lateralmost portion of your fallopian tube. And at the very end of the infundibulum is where you have the fimbria, these little finger-like projections. And they'll help to sweep up the oocytes, all right, into, all right, the uterine tubes here. Okay, so usually what will happen is, all right, the infundibulum near the time of ovulation will drop down over the ovary there. Okay, when it's not close to ovulation, okay, it's not draping right over it. Okay. So the next portion is the ampulla. Important that you know this. I said this before. This is usually where fertilization takes place. It's medial to the infundibulum, lateral to the isthmus. All right. Then just before we get to, all right, the actual uterus, all right, we have this really narrow structure here called the isthmus here. All right, and this is the last portion, all right, of the fallopian tube before it actually connects and joins up with the uterus here. All right, the part of the fallopian tubes that joins with the uterus, we refer to that as the uterine part. All right. All right. So the makeup of the uterine of the fallopian tubes is going to be our normal 3 layers. All right. The innermost layer is the mucosa. All right. Then we have the muscularis, the middle layer, and then the outermost layer. We call that the serosa if it's covered by, all right, serous membrane. And in this case, it is. All right. Our broad ligament there. All right. So the internal lining, the mucosa, is going to be made up of ciliated columnar epithelium. The operative word here is ciliated because it's going to help sweep the oocyte towards the uterus here. All right. Also, okay, if we're looking here at the fallopian tubes here, all right, you have these folds, all right, that go longitudinal from end to end. Okay, not to be confused. Most of the time when we're looking at a tube, all right, like for example, when we talked about the vagina, we had transverse folds that go from side to side. All right. Well, in this case here, all right, in the fallopian tubes, they're longitudinal or linear folds. All right, they go from one end to the other end here. All right, so it kind of makes the lumen a little bit smaller here. All right, but the important thing is it's lined with cilia, and that's going to move the oocyte towards the uterus there, okay? Because the oocyte doesn't have any flagella of its own, or well, doesn't have a flagella. Sperm do, oocyte doesn't. So it relies on 2 things. It relies on the cilia beating it, that's a bad term, but you know, sweeping it, all right? Sweeping it towards the uterus, but also it relies on this layer here, the muscularis layer. Okay, because those layers of muscles, all right, those smooth muscles will have alternating contraction relaxations, which will help again propel the oocyte towards the uterus there. Okay, and then our outermost layer is the serosa. All right, that is of course made up of the serous membrane. Questions about that? Again, you should know all this. All right, I'm not going to assume, but it's always nice to get a review. Okay, so your brains don't have to work too hard when you're studying for this material for your test on Tuesday. All right, let's get to the uterus here. Okay, our uterus again, all right, is a pear-shaped organ, and we've already talked about its purposes. We'll break it down here in a moment. All right, but it can be positioned either, and in most cases it should be anteverted, which means the fundus in the body of the uterus will lay on top of the urinary bladder. Okay? In a small population of people, it's retroverted. All right? And what that means is the fundus in the body are laying up against the rectum. Usually happens in the older population, all right? But some people actually will have a retroverted uterus. Okay? So just keep in mind that most folks are anteverted. Okay. All right. So our uterus has a cavity in the center. All right. We refer to that as the lumen. We'll get into that in a moment here. All right. But the important thing for our uterus here is 1, it's a site for implantation for the egg, all right, not the egg, for the pre-embryo to implant itself. All right. Also, it's going to provide, all right, the nourishment, the walls of the uterus, when we start to build up the uterine lining, all right, we are going to help sustain and nourish, all right, the implanted pre-embryo, all right, as it develops into an embryo, fetus, and whatnot. Okay. And then of course, once the fetus has reached full term and it's time for the fetus to join us here in the world, all right, the uterus helps us with removing it from mommy by, I hate this word, ejecting the fetus. All right, just like I feel like it's one of those like an airplane ejection seat or whatever, you know, just get out of here. All right, kick the fetus to the curb. All right, So in the case that it isn't fertilized, all right, then we're going to see, all right, again, shedding of the functional layer, all right, and also to help with the shedding, to kind of shake off some of the pieces off of the wall, the smooth muscle there in the uterus and the muscularis layer will contract a little bit. That's why some folks and some female patients that I've had, they'll complain of cramping, all right, guess what? That is the myometrium doing its thing to try to kick off some of that functional layer there, okay? And of course, the blood supply to the uterus comes from the uterine arteries. You need to know where they come off of, the internal iliac, right? So our descending abdominal aorta, all right, will split off into the right and left common iliacs, and then the common iliacs will then split off into the external and internal iliacs, all right? So this is a branch off the internal iliac. Any branch that comes off the internal iliac is usually going to go to somewhere in the pelvic cavity, all right? It'll supply any of the tissues, organs in the pelvic cavity there. All right, so for the regions here, the fundus is that dome part on top of the body of the uterus. I'm going to try my best to kind of draw a picture here. All right, so that's not too bad. All right, so the dome part, here's the fundus right here. All right, and then from here down to that portion, that's going to be the body. All right, that's what we'll see, that nice thick wall, all right, from the myometrium there. And then as it starts to constrict towards the bottom here, all right, that's going to be the isthmus. And then at the bottom of the isthmus, all right, that's where we're going to have our cervix. And the cervix is like a donut. Well, it's going to look like this. So the cervix is like a donut. All right, it's got a hole in the center. Okay, and then on the other side, inferior to the cervix, is going to be the vagina. All right, so let's talk about our cervix here. Okay, so again, the portion that's going to be internal, all right, of the cervix, that's going to be in the internal portion of the uterus, that's the internal surface there. So the opening is called the internal os. That's right here. All right. The external os will open up into the vagina. Okay. And then, of course, you have this little canal here. That's the cervical canal. Okay. Now, it's the external os, and I've said this before, is when you go in for a pap smear, they are taking skin samples off of the external os. It's made up of that non-keratinized, so we know that all those cells are living, okay? And so they're going to observe the size and shape of them and see if there's any abnormalities, like any type of metaplasia, okay, that's going on there. Okay, so it's non-keratinized, stratified squamous epithelium. Okay, and also we'll see, all right, the mucus plug there. Okay, and a non-pregnant normal female, all right, it's the mucus plug is to prevent infection here. Okay, but around ovulation, it thins out to make it easier for the sperm to traverse and enter in from the vagina, making their way. They literally have to go up the vagina, through the uterus, and into the fallopian tubes to find that expelled oocyte there. So they have to do, it's quite a journey. We'll talk a little bit about what happens with the sperm here. All right, 3 layers to the uterine wall. The outer layer, all right, the perimetrium, all right, this is going to be where you see the broad ligament, all right, draping over it. All right, the middle layer, aptly named myo, muscle, all right, made up of 3, not 2, but 3 layers of smooth muscle, all right, which you'll need every single bit of, all right, especially during childbirth to help, all right, expel the fetus, all right, from the uterus here. Okay, so this is the thickest of all 3 layers. Okay, the myometrium, like the heart, all right, the myocardium, all right, the middle layer of the heart is going to be the thickest, all right, compared to the endocardium and I was going to say ectocardium, all right, pericardium, okay? All right, but let's talk about the really important layer, and that's going to be the endometrium. Okay, so there's two parts to the endometrium. All right, you have the deep layer, which is the more permanent layer. All right, and that's the basal layer. That's the boring layer. All right, B basal, B boring. Nothing really goes on there. All right, so not a lot of changes will occur in the boring or basal layer. All right, but the layer that's more superficial, that's the exciting layer. All right, this is the one I've been talking about. It's the functional layer. All right, it becomes functional at the time of puberty here, and this is the one when you heard me saying that estrogen and progesterone were getting ready, all right, to prepare the uterine lining for implantation. This is the layer that I'm talking about. Okay, so estrogen and progesterone play a huge role here. All right, so obviously if there's no fertilization, this is the layer that gets shed off during menses. Okay. Questions about, I gotta take a sip. I've been talking nonstop. So I was at a staff meeting today at lunchtime, and we wanted to do some outreach program, of course, in my practice, to the United States Postal Service. And apparently everybody in the practice unanimously volunteered me, because apparently I'm the only one that can talk to people. So they volunteered me.
You got voluntold.
Yes, I got voluntold. Yes, I was voluntold. Okay, so enough with the uterus. Let's finish up strong and talk about the vagina here. Last part. Okay. So the vagina is the most inferior portion to the female reproductive tract there, all right? And so this is the passageway that connects, all right, the outside world to the uterus here, all right? Plays a huge role in childbirth, all right? It is the birthing canal. Also during intercourse, this is the area that the penis is going to be inserted into, all right? And finally, during that period of time, all right, where in menstruation, all right, where the endometrium, the functional layer, starts to shed off, all right, it evacuates out through the vagina, all right? So as you can see, the vagina plays several important roles here, all right, and a lot of functions for the reproductive system here, right? The innermost layer, the mucosal layer, is also going to be lined with non-keratinized stratified squamous epithelium, all right? Makes sense, stratified, because it's going to have to experience a lot of mechanical stress. All right, so we'll see we line that area with the non-keratinized stratified. All right, normally, all right, the secretions in the vagina are going to have a low pH. Okay, that poses a problem for sperm. All right, low pH poses a problem for a lot of things. Okay, we know its physiological effects on proteins, starts to cause things to break down, but it's good, all right, in the flora of the vagina because it helps to prevent from infections and certain pathogens, all right, from creating opportunistic infections there. Okay. Also, when I was talking about the difference between the vagina and the fallopian tubes, in the vagina, all right, it has rugae. All right, but its rugae or folds go transversely. Okay, they don't go longitudinally; they go from side to side. All right, then the opening there to the vagina. All right, the vaginal opening or the vaginal orifice there. All right, in the younger population, will have a membranous covering. All right, called the hymen. Not everybody has it; most people do. All right, but it is this barrier here that covers the vaginal orifice there, and it's called, and there's different presentations as to how it appears, all right, but that membranous barrier is what we refer to as the hymen there. The two other layers, remember there's always three layers, all right, so the middle layer is the muscularis, all right, it only has two layers, an outer and inner layer of smooth muscle, and then finally the adventitia, all right, again, it's not a serous membrane here. All right, in this case, it's an areolar connective tissue. It's a loose connective tissue. All right, and as such, all right, you want it to be a loose connective tissue because then you can have a lot of protein fibers in that loose connective tissue. All right, specifically elastic fibers. All right, those elastic fibers will allow for the dispensability, all right, for whatever is entering the vagina or coming out of the vagina. For example, childbirth, okay? So those elastic fibers help with that. Quick picture, all right, of what we were just talking about: ovary, ovarian ligament, and here's the fallopian tube, the different parts of the fallopian tube, all right, the uterus with the fundus, the body. Down here is the cervix, all right, internal os, cervical canal, external os, and then the vagina down here. All right, let's talk about the uterine cycle here really quick. Well, there's really not any quick way to talk about the uterine cycle. All right, so we talked about what goes on with the ovaries during the ovarian cycle and what hormones are going to be affecting, all right, what in the ovarian cycle. So now we're going to talk about what happens to the uterus during the uterine cycle and what happens to the uterine lining here. Because remember, we got to build it up, then we got to tear it down, okay? We don't have to tear it down if fertilization occurs, okay? So obviously the uterine lining, the endometrial lining, is going to be influenced by these two hormones here, okay? So to make it easy, we got 3 phases, just like we saw with the ovarian, all right? We have the menstrual phase, that's going to be in the beginning, all right, of the menstrual cycle. Then we have the proliferative and the secretory phase, okay? Again, we're going to deal with a 28-day cycle, but at the same time, this varies. It could be anywhere from as short as 21 days, 35, and like I told you, that one patient that I had, I mean, she went months, okay? So it varies for the menstrual cycle there, okay? All right, so the first part of the menstrual cycle is going to involve the sloughing off period, bleeding, 1 to 5 days here, okay? So at the end of that phase, we enter into our proliferative phase, because now we've just sloughed off the old layer. Now we're going to grow a new layer, all right? So now we're going to develop a new functional layer to the endometrium here, okay? So we're going to see some overlap, all right, between what's going on with the follicular growth, all right, and the follicular growth and the ovary secretion of estrogen. Okay, so we're going to see this role. I'm going to try to draw that together, and I tried my best to kind of explain how estrogen, what its effects were on the uterine lining here. Now we're going to kind of draw all that together with what's going on with the follicles and the uterine lining here. Okay, so the last part of the secretory phase of the menstrual cycle is the secretory phase. This is where we get that huge spike in progesterone. All right, comes from the corpus luteum here, all right, where we really build up that lining, all right, because at day 14, and if you look here, day 15 is the beginning of the secretory phase. Day 14 is when the oocyte is expelled from that mature follicle. But I don't know if you remember, I told you that it can take about 6 days for the oocyte from ovulation getting expelled from the ovary to travel down the fallopian tube into the uterus there, okay? So during that period of time, we are actually going to be really prepping, all right, the uterine lining there, all right, thanks to progesterone there, to help increase the vascularity, and not only that, all right, glandular development, all right, in the functional layer there of the endometrium there, okay? And obviously, if none of that occurs, if fertilization doesn't occur, then none of this will be sustained, and we tear it down only to build it back up, okay? So after we see a huge drop in progesterone, that's when we see the functional layer slough off. If there's no drop in progesterone, all right, because the corpus luteum is being sustained, all right, because of the HCG, then that functional layer won't slough off, all right, because the body assumes implantation has occurred. So the corpus luteum sustained, so progesterone will be produced to help maintain that functional layer there. Going back to here. So here you can see, all right, here's ovulation has occurred, LH surge, boom, okay, estrogen starts to fall off a little bit, now we can see a huge spike, all right, in progesterone. And look at the correlation. Look at the progesterone secretion increasing. Look at the uterine lining. It's also increasing. Okay? This happens during the luteal phase of the ovarian cycle. So the corpus luteum is going to be releasing both progesterone and estrogen, but progesterone is going to really be pushing, all right, the development of the uterine lining there for implantation. Okay? I think we can skip the breast. We've already talked about the breast in lab. All right, I'll run through it really fast. Well, then, therefore, I wouldn't be skipping it if I'm going to run through it really fast. All right, but real quick here. All right, when we talk about the breast here, its job is to produce breast milk. All right, breast milk is high in these macronutrients here: proteins, fats, all right, lactose, sugar, so everything: proteins, fats, carbohydrates. All right. So it is an exocrine gland, and as such, as an exocrine gland, it means it has ducts. It's not on the page here. Okay. So these glands are going to be divided up into lobes, and then those lobes will be further subdivided into lobules. Okay. The secretory portion inside these lobules are what we refer to as alveoli. They look, bless you, they look like a grape here. All right, and then at one end we have the duct system here. Okay, so the hormone that helps to produce milk, do y'all remember the name of it? Well, that's milk ejection. Prolactin. Prolactin will produce PR, all right, PRO for prolactin, produce. All right, oxytocin. You think of it, well, oxytocin expels the fetus because it helps with contractions of the uterus. Well, it also helps to expel milk out of the breast, okay? So we'll see, all right, in a pregnant female, and especially in a female that is nursing, we'll see the number of these alveoli in the ducts increase quite a bit, all right? So all the alveoli will drain into these ducts from the individual lobules, which will eventually drain the individual lobes, and then from the lobes, it'll drain into what we call the lactiferous ducts here, okay? And it's the lactiferous ducts that all drain close to the nipple and the areoli, all right, into this structure here called the lactiferous sinus, and that's where the milk is stored until it's time to nurse, okay? And then when it gets emptied, then the alveoli, all right, will be stimulated again, all right, to produce more milk. All right, so here you can see that's the lactiferous sinus there. That's where the milk will be stored here, okay? All right, so lactation is going to involve two hormones. All right, I don't think I talked about this in lab, okay? So at this point, after, this is important, after giving birth, prolactin will be released from the anterior pituitary. Okay? Where does, oh, it says it up there. All right, I was going to say, where does oxytocin come from? All right, it comes from the posterior pituitary, but the hypothalamus makes oxytocin. All right, and then the posterior pituitary stores the oxytocin. So prolactin is used for milk production. All right. And prolactin will also increase, all right, the number of glands here and ducts and whatnot. All right, oxytocin, all right, is required for milk ejection. All right, and we'll talk more about oxytocin, all right, in chapter 29 when we talk about development and the actual childbirth process, because oxytocin plays a role in uterine contraction. Okay. All right. Finally, let's talk about the female sexual response, okay? So in the female sexual response, all right, when we're talking about the stages, the first stage is the excitement stage, or phase, excuse me, all right? So pretty much any reproductive organ that can fill up with blood will do so, all right? So the clitoris, all right, the bulbs of the vestibule and the labia, both the labia majora and the labia minora, will both become fully engorged with blood, all right? While this is occurring, believe it or not, the nipples become erect, but the uterus if it's possible, can become more erect, okay? So when this happens, all right, we have to prepare for intercourse, okay? So that means if coitus is going to occur, all right, that means we need to provide lubrication, all right, for the actual act. So we'll see an increase in production in the mucus, all right, of the glands in the vagina, all right, and in and around, all right, the vaginal vestibule, all right? That's what we call the vestibular glands there. So not only in the vestibule, all right, the vestibule is where the opening to the urethra and the vaginal orifice is located, so we'll see an increased production of mucus there. We'll also see an increase in production of mucus inside the vagina, okay? And of course, all right, this is going to stimulate the autonomic division, the brain, what am I trying to say? The division of the autonomic nervous system that is going to help to promote this is the sympathetic, the fight or flight, all right? So, of course, we're going to see an increase in heart rate, blood pressure, and respiratory rate, okay? All right, I know we're spending a long time on the female reproductive system. I feel like the male reproductive system is boring compared to this, all right? So let's talk about the latter portions of the female sexual response. Of course, we have orgasm, which has been described as intense pleasure and a release of tension, all right? But we'll see during actual orgasm, literally a rhythmic contraction of the vaginal walls there and the uterus, all right? And this can last for several moments. Now, that's always followed by the resolution phase here. And that's basically when everything goes back to normal, okay? And so the vaginal walls relax. Any tissue that was engorged with blood, now the blood can leave. But the interesting thing is that there's no refractory period for women. Women can have multiple orgasms, all right? Men, unfortunately, do have a refractory period, all right? So there's no refractory period for women. Okay. That leaves me onto the male reproductive system, okay? So again, some of this will be review, all right, for you, so I'm not going to go too slow, all right? But I'm not going to go too fast either, all right? So primary organ of the male reproductive system is the testes. Primary organ for the female reproductive system was what? I think I heard it. Ovaries, okay? So of course, all right, our testes are the primary organ, all right, and everything that's going to be involved in what goes on in the testes, we need a way to send it somewhere, all right? So that leads us to the duct and tubule system, all right? That's going to go from the testes to the penis. Then we have our male accessory glands. Prostate gland is one of them. We have the Cowper's glands. Then obviously the penis, okay? So those are all considered the accessory reproductive organs there. So let's talk about our primary reproductive organ for the male, okay? Scrotum, there are two. They sit in this, did I say scrotum? Testes, there are two. It sits in the scrotum, external to the body, all right? And so it is here that this organ produces sperm and androgens. Androgens are going to be the male hormones there, okay? During development, the testes start off inside of the male, all right? And as they're growing inside of mommy, all right, they descend from the peritoneum, all right, in the abdomen, and they move exteriorly. During that time, they get covered by the serous membrane, the peritoneum, believe it or not, right here, all right, as they're descending. But only the anterior and lateral portions of the testes are covered with that serous membrane, okay? Call this the tunica vaginalis, all right? We have an inner and outer layer because it's peritoneum, all right? So we have a parietal layer and a visceral layer. And as such, because they're two layers, we have a cavity in between, and it's filled with serous fluid there, okay? All right, so that's the most external covering to the testes. Deep to that, we've got this white covering called the tunica albuginea. All right. So here is what it's made up of: a thick, dense, irregular connective tissue. All right, like a fibrous type of material here. All right, and inside, all right, the testicle, we have this structure here called the mediastinum testes. We'll talk about this here. All right, but this is this region here. All right, well, we'll see a thickening of the tunica albuginea. All right, but this is where we see all these structures, all right, that are going to be responsible, all right, for the production, the nourishment, the sustaining of sperm here. So we're going to see blood vessels, ducts that are going to move sperm, all right, from the seminiferous tubules, all right, into the epididymis. All right, we're also going to have lymphatic vessels for drainage, and then of course nerves. Okay, so our testicles are divided, all right, by certain compartments, and we call that septa. All right, and so we'll see about 250 small compartments inside of the testicles here. Okay, and in those septa is where we're going to find the seminiferous tubules. And it's the seminiferous tubules that we're going to see the production of sperm here. All right. So a couple different types of cells are going to be present in, all right, these structures here. The first one here is going to be the sustentacular cells. They are support cells. Most importantly, they are non-dividing. They don't divide. Okay. The sperm divide. The spermatogonia divide. All right. Sustentacular cells do not. All right. So they're going to nourish the sperm, but most importantly, inhibin. We already know what inhibin does. We saw what it did in the ovaries. Similar here. Inhibin is going to prevent the release of the follicle-stimulating hormone, all right, from the anterior pituitary gland. When sperm levels get too high, all right, got to shut it down. Okay, you got to shut it down. So inhibin gets released, all right, stops the production of FSH, all right, and that prevents, all right, the growing, all right, the dividing for sperm and the maturation of sperm here. Okay. Questions so far? Okay. Already talked about the blood-testis barrier. All right, interstitial spaces obviously are going to be the spaces in between or surrounded by the seminiferous tubules. But I want to talk about these guys, interstitial cells. Okay, these are going to be in the interstitial spaces, which are the spaces outside of the seminiferous tubules. All right, but most importantly, these cells produce our androgens, testosterone, for example. All right. It's not the only place that testosterone is produced, right? It's also produced in the adrenal cortex, but very small, minute amounts, okay? Most of it comes from the testes here, right? So the interstitial cells are stimulated by LH hormone, okay? Make it known, LH hormone. All right, so if we see here, all right, here's the epididymis, okay? Here's the testicle, all right? The testicle has these small septa, these lobules here loaded with the seminiferous tubules. These seminiferous tubules will drain into, all right, what we call the ret testi, which is found in the mediastinum testi. And the ret testi is just this network of ducts that are going to drain from all these individual septa here into the ret testes, and then from the ret testes, they're going to drain into the epididymis. And the epididymis is where the sperm go to mature. Okay, it's like school. They're going to go and grow up, okay? And a couple changes will occur inside there. We'll talk about those changes during the maturation of sperm here. All right, so can't talk about the reproductive system without talking about how it's regulated by hormones, okay? Same scenario in regards to, all right, what governs what, okay? Our hypothalamus is going to secrete, again, gonadotropin-releasing hormone onto the anterior pituitary, and we know the story. Then the anterior pituitary is going to release the follicle-stimulating hormone and the luteinizing hormone, all right? And both of those hormones, all right, FSH is going to stimulate spermatogenesis, okay? Luteinizing hormone is going to stimulate androgens, okay? So know this, LH is going to stimulate interstitial cells to secrete testosterone. FSH is going to stimulate the sustentacular cells, all right, to secrete this androgen-binding protein. Haven't talked about this before, all right? But this androgen-binding protein, all right, is going to stimulate high levels of production of testosterone in the testes, okay? And so it helps to ensure those high levels, all right, so we can actually increase spermatogenesis, all right? So we're going to see an increase in spermatogenesis, but also it's going to inhibit gonadotropin-releasing hormone secretion, all right? So it's going to provide us with a negative feedback effect, okay? So it's important that you know that. If we inhibit the gonadotropin-releasing hormone from being released, then, all right, the pituitary gland is not going to release, all right, FSH and LH. Okay? So that's one way of how we can monitor the levels of sperm that are produced, all right, through that negative feedback system. The other one I've already talked about, inhibit. Okay? When sperm count gets too high, inhibit is released. It inhibits the secretion and the release of follicle-stimulating hormone. All right? And again, it's another negative feedback system. We should all be thankful for these negative feedback systems. Okay. And finally, all right, testosterone is going to provide, obviously, our secondary male sex characteristics for men, hair, armpit hair, all right, axillary hair, pubic hair, all right, increase in skeletal muscle mass, facial hair, all right, obviously thickening of the vocal cords there for a deeper voice, all right, and it also affects sex drive. All right, so when we talk about hormonal regulation here, this picture, again, of course, always with a picture view. I think it's a little bit easier to see. All right, so starting here, all right, hypothalamus is releasing the gonadotropin-releasing hormone, which is going to stimulate the anterior pituitary to release the follicle-stimulating hormone and the luteinizing hormone. All right, obviously the follicle-stimulating hormone is going to cause an increase in, all right, spermatogenesis. All right, we're going to start, which we'll talk about here. All right, probably not tonight. The luteinizing hormone is going to stimulate the interstitial cells to release androgens. Okay. Also, all right, we can see, depending on what's occurring here, all right, our sustentacular cells, all right, can release inhibin, all right, if our sperm count gets too high, to stop this process from occurring. All right. We'll also see the sustentacular cells and the interstitial cells are going to play a role in the testosterone production here, in the levels here, which will also play a role in spermatogenesis here. If the testosterone levels are getting too high, we're producing too much spermatogenesis, then again, we'll have a negative feedback inhibitory effect on the hypothalamus there. All right. Let's take a break on that. All right, and let's give it about 10 minutes.